Good evening, everyone. I hope everybody's doing okay this evening on this cold Cleveland night. Thank you for joining us for this important presentation, Be Fierce, a program addressing health disparities and lupus. All lines have been muted to ensure the quality of the audio and provide a distraction-free learning environment. At the end of the presentation, we will allow for a short Q&A. You can use the comments section to send questions, and we will address as many questions as time allows. At the end of the program, we will send you an evaluation. We ask that you please provide us with feedback to ensure that we best serve our lupus community by providing engaging future programming. Each person that completes an evaluation will be entered into a random drawing for a $25 gift card. We will announce the winner on Monday. I'd like to take a moment to read a brief disclaimer. The Lupus Foundation of America, Greater Ohio Chapter, does not give medical advice to patients regarding their treatment of lupus. Your physician is the best source of information regarding medical management of your disease. This program is available for informational and educational purposes only, and the content provided by other providers and/or professionals within the context of this program is not necessarily the opinion of the Lupus Foundation of America, Greater Ohio Chapter. We will now begin the program. Thank you for joining us for Be Fierce, a program addressing health disparities and lupus. My name is Adrienne Fernandez, and I have worked with the Lupus Foundation of America, Greater Ohio Chapter for the past 8 years. I am also a lupus patient. In my work at the Foundation, I have seen firsthand the struggles that impact minority communities. Disparities in health outcomes and health care among different racial and ethnic groups is well documented. This is especially true in chronic and acute disease conditions such as lupus, diabetes, cardiovascular disease, obesity, hypertension, asthma, and more. The reasons for these disparities are complex and multifactorial. Disparities in health and healthcare shine a light on our public health system and highlight areas that need tremendous improvement. One thing is for certain: in order to close the gap and create health equity, we must persist in our efforts to research, discuss, engage, educate, and more importantly, change the system that allows for these variances. We have mountains to move, but we cannot move them alone. The program may be small, but with each small audience and each little change, we make progress towards health equity. So I thank you very much for joining us this evening and for taking time to listen and learn. I'd like to take a moment to recognize our generous sponsors. Funding for this program has been made possible by an earmark from the state of Ohio and managed by the Ohio Department of Health, as well as the Ohio Commission on Minority Health and GSK and Us and Lupus. We would not be able to hold important programs like this without these pillar organizations. Thank you to each of them for their generosity and their continued support. Our panel today includes Leslie Vizcarra-Tierney, RN and BSN of the Lupus Foundation of America, Greater Ohio Chapter, and Yvonka M. Hall, MPA, of the Northeast Ohio Black Health Coalition. In addition, we have Cindy Fisk, BSN from GSK and Us and Lupus, joining us this evening to begin our program, and she will also share some helpful tools with us at the end of the evening. Cindy, who most of you, I believe, should recognize by now, is the Patient Engagement Liaison for GSK and Us and Lupus from Mechanicsburg, PA. She has over 25 years of experience in the healthcare and pharmaceutical industries. And in her current role, she educates patients, families, and healthcare practitioners about lupus. I am sure you will all help me in virtually welcoming Cindy Fisk.
Well, thank you, Adrienne. Can you all hear me? Perfect.
Yes.
Well, thank you, Leslie, Adrienne, and the entire LFA of Greater Ohio for including us this evening. It really is an honor to be a sponsor for this important event focused on addressing health disparities and lupus. You know, as a supporter and a committed partner to the LFA Greater Ohio and the broader lupus community since 2011, we've learned that to be truly successful in fighting lupus, it really takes all of us coming together, working towards common goals such as early diagnosis, adequate funding for lupus research, and quality healthcare that's affordable, accessible, and helps to close the gap on healthcare disparities. And these are areas that I'm passionate about, GSK is passionate about, and we're grateful that the LFA Greater Ohio is passionate about too. And I really would be remiss if I didn't thank them for their tireless efforts to support patients living with lupus. I just want to highlight a few areas that we've collaborated with the LFA on to advance each of these goals. We're proud to support LFA's Alpha project, which is addressing lupus pillars for health advancement to reduce that time to diagnosis, which is nearly 6 years on average. Simply unacceptable, and we must reduce the time to diagnosis and the associated burden that goes along with that. We're also collaborating on strengthening our reach into communities with women of color who are disproportionately affected by lupus by supporting LFA's multicultural efforts and soliciting the LFA's input on how we as a company can do a better job. And we also need to improve the dialogue between those that are living with lupus and their healthcare team. This is so important because the research is showing that physicians may not perceive when patients are suffering. And we've been honored to partner with the LFA Greater Ohio to bring our Us and Lupus resources to multiple events in 2021. Us and Lupus is a program that helps those living with lupus to have more open, more honest conversations with their healthcare team. And although we're still not engaging face-to-face yet, we're continuing to make these valuable resources available virtually at usandlupus.com. So I'm going to share more about Us and Lupus towards the latter part of the program and as we wrap things up, but for now, I'll turn it back over to Adrian and Leslie. So thank you.
Okay, well, thank you, Cindy. We know that GSK and Us and Lupus are committed to this this cause, and we thank you so much for your participation this evening, and we couldn't be more grateful as well. So with that in mind, I know we'll hear more from you towards the end of the program, but right now I'd like to introduce Leslie Tierney, who many of you know, of course, RN and BSN. She has over 20 years of experience as both a volunteer and an employee of the Lupus Foundation of America, Greater Ohio Chapter. In her current role as Vice President of Operations and Patient Navigator, she provides oversight in all aspects of chapter operations. She also works with lupus patients daily to ensure that they have the tools and the resources necessary to manage their lupus successfully. She is truly passionate and dedicated to the mission and is inspired by the patients that she works with. I see that from her daily, so I can tell you that is what she is doing much of her time. Her background in nursing makes her uniquely qualified to assist the people who reach out and need services from the Lupus Foundation of America, Greater Ohio Chapter. Welcome, Leslie.
Thank you, Adrian. And I know I provided you some of that bio and you tweaked it a little bit, so thank you for highlighting the things that I work on with the foundation, so thanks for that. But good evening, everyone, and thank you for joining us. As I'm navigating my PowerPoint presentation here, thanks for joining. It looks like we have a good crowd, and tonight we have a very important topic to talk about, disparities in lupus. And just a quick overview here, we'll be looking at the definitions of disparities and then do a quick overview on lupus. Then we'll dive a little bit deeper into lupus disparities by looking at contributing factors, and I'll provide examples and quick overview of research and data that we found. Then wrapping up, we have a few ideas on ways we can reduce health disparities and continue to move forward. So first here, the disparities definition. Disparities can be a complicated topic to discuss because there are different definitions and understandings of disparities in its context. Definitions from our government standpoint by the National Institute of Health are health disparities are the difference in the incidence, prevalence, and mortality and the burden of a disease and other adverse health conditions that exist among specific populations and groups in the United States. So in health disparities, we think of the impact on people, right? And then healthcare disparities is the difference in the access or availability to facilities and services. So with healthcare disparities, we think about accessibility. We will look into these different levels that disparities and how they can occur. Lupus patients all have different experiences of how lupus can affect them specifically. we know that lupus impacts each patient differently, gauged by the severity of their disease. Also, we know that it takes an average of 6 years for a lupus patient to receive correct diagnosis. What we see happening is that patients aren't able to access the right physician initially to help treat them. So limitations on racial and ethnic category. So here, hopefully you can all see my screen. You see a really long definition of racial and ethnic categories defined by the federal government. We can see that this long definition and breakdown is it's complicated. There are a lot of different categories that we can define each person in America. Sometimes there's not even a category that fit for certain individuals on forms. Personally, for me, I struggled with the definition of my own ethnicity. As a child, I was confused as to what it meant and basically who I am. I distinctively remember a moment of recognizing when I was different. My first experience was I think kindergarten, when an adult asked me, "Oh, where are you from?" And I eagerly responded back, "I'm from Maple Heights, Ohio." And the adult chuckled back at me and responded, "No, I meant where were you born?" And I responded, in Garfield Heights, Marymount Hospital, that's where I was born. And the adult chuckled back again, "No, I mean, where are your parents from?" And, that's when the confusion kind of struck in. I'm like, right, I already answered this. I live with my parents in Maple Heights, Ohio. And it wasn't until they asked me, "No, where were your parents born?" that it made sense to me what they were getting at. The question that they were trying to ask 6-year-old me, what are they talking about? I said, "Oh, my parents are from the Philippines. They were born in the Philippines." And that was that first instance of recognizing I was a little bit different. That same year, standardized testings started. You fill in all those little bubbles, and I remember putting in my name, and it came to the option of ethnicity. And the options back in the 80s was Black, white, and other. And at that time, I remember thinking, I don't want to be other. I really didn't know what that was, and I was concerned about it. And I remember asking my friends at recess, "So what you put for that first question there?" And they're like, "What first question?" And I said, the one that said white, Black, or other. And they asked me, "Well, what did you put?" And I said, "Well, I put other." And at that time, my classmates, predominantly white, they picked on me. And it was that particular moment that I realized I was just different. And, I'm bringing this up because it's important for us to know that in research and finding these definitions and variables, the government still here, has listed, if you can see here, it's other Pacific Islander, if you can see my notes clearly enough. And so, I'm still categorized as other even by the government's definition. Despite these limitations associated with these categories, they do provide the framework to begin our discussion. The different research may vary in definitions in race and ethnicity, and the government's definition are not always the same definition used in studies. So there brings in a little bit of confusion with, definitions to ethnicity. So jumping in just a little deeper with what is lupus, a quick overview, right? And I know a lot of us know these things, but just in case you forgot, I'm going to go over them. A quick review. In lupus, something goes wrong with the immune system. Our immune system protects us from foreign invaders like viruses, bacteria. Autoimmune means our immune system can't tell the difference between foreign invaders and your body's own healthy tissue, which then creates the autoantibodies. It is those autoantibodies that attack and destroy healthy tissue. It affects various organs for whatever reason. Lupus likes to attack the kidneys. We don't exactly understand why. And it presents different in each patient. Lupus is a chronic disease with acute flares. The signs and symptoms can last longer than 6 weeks to years. And the morbidity is variable. It is one of the highest rates of mortality with rheumatic diseases. So who gets lupus? Approximately 1.5 million Americans have a form of lupus. 5 million people throughout the world have a form of lupus. We estimate that 60,000 Ohioans have lupus, and about 16,000 Americans develop lupus each year. Women are approximately 10 times more likely to have lupus over men, and we know that it strikes women in the childbearing years between the ages of 15 to 44. Women of color are 2 to 3 times more likely to be affected. Children, teenagers, men, and elderly can develop lupus, though. More people have lupus than AIDS, cerebral palsy, multiple sclerosis, sickle cell anemia, cystic fibrosis combined. Many patients are misdiagnosed, and some even die without even knowing they had the chronic illness. So that brings us to the question, does lupus affect people equally? And I think we all know that it doesn't. It affects everyone differently, which is what makes lupus so complicated. So here we're going to look at the factors in lupus disparity. So here are some factors and outcomes to lupus. There are different levels that patients face. There is the difference in the healthcare system. There can be a difference in the individual patient or their community. Then the difference in the interface where the two factors meet. All of these variables result in a different outcome. We know that all lupus patients are not alike. Some have mild symptoms. Lupus could only affect their skin. Some have more severe symptoms, with the first initial symptoms being lupus attacking their kidneys right away. So how can patients access their care? How do they access it? So we're going to investigate and try to best understand these differences today. So first off, the difference between men and women. The difference in sex. Studies indicate that lupus is 9 times more likely in females than to men. We're not exactly sure the reason for this, but clues indicate that there are some gene correlations there. We do see in studies that women are more likely to be diagnosed during their childbearing years, so there are clues to there being hormones being a trigger for lupus flares. But yet this is not still fully understood, and there needs to be more studies to closely recognize what's happening there. In general, men have the more severe disease than women, more severe disease activity than women. A study concluded that lupus nephritis, lupus in your kidneys, may be worse and more severe in men. There are also more indication in heart disease and stroke in men with lupus. However, results of many of these studies are not conclusive, given the limited number of male participants. Larger studies are just needed to better define the disease activity related between the differences between men and women. We do see lupus patients at an increased risk, increased risk for cardiovascular disease, such as heart attacks, strokes, with increased risk factors of hypertension, diabetes, smoking, to which much of the general population is also susceptible to. But cardiovascular disease affects over half of all adults over the age of 60 and is the major cause of mortality in lupus patients. Amongst the general population, risk factors for cardiovascular disease include hypertension, diabetes, and high cholesterol. Certain behaviors also like smoking, inactivity, alcohol consumption can all contribute to a person's risk factors for developing cardiovascular disease. A study has found that men with lupus may have an increased risk for cardiovascular disease compared to the female patient. So again, we need to know the majority of lupus patients, we know the majority of lupus patients are female, when men comprise only about 4 to 18% of those with the disease. The male to female ratio in lupus varies between age groups as well. Among children and children and early adolescents, 1 in 4 patients diagnosed are male. Between the ages of 15 to 50, males represent approximately 6 to 10% of patients diagnosed with SLE. After the age of 50, the disparities drop slightly as men comprise 1 in 9 new cases. So lupus in the ethnic minorities. A study has compared ethnic communities to lupus in the minority population. A study named Lumina, which is a cohort study, had some findings. The findings of the study is that lupus incidence rate is highest among Black women. The incident rate is higher by 4 times those of white women. It affects up to 1 to 250 Black women in the United States. The disease activity is more severe overall. Lupus is developed earlier in life, and there's greater disease activity at the time of diagnosis. There is more neurological problems such as seizures, hemorrhages, and strokes. What the study was concluded is that also Hispanic, Asian, and Native American population are more likely to develop lupus. So early lupus onset in Black females. Another study shows that the mean age onset of lupus is younger in Black women. So here you see the purple line represents Black women, the light purple line represents white women, the green line represents Black men, and the light gray line represents white men. We can clearly see that lupus in Black women are impacted with lupus earlier in life and at a higher rate than white women. We can also see that with age, the rate slows down and becomes less frequent for diagnosis. So this chart here, the chart represents an occurrence and increased earlier damage in Hispanic and Black population here. So we're looking at the damage index for the minority population. In this chart, they chose to break down the ethnic groups and look at Hispanic Texas and Hispanic Puerto Rican, African American, and Caucasian. So this is one of those clearest examples of the slight variances in looking at different ethnicities and population and how the studies look at different ethnicities. So I'm not quite sure why they chose to break it up that way, but that is what the study chose. So this chart shows us at the time of occurrence of initial damage as a function of ethnicity in 158 lupus patients in the Lumina study, the cohort study. The survival curve is constructed using data from all patients and not only from those developed with initial damage. The color line represents from Texas is the green line, Hispanic from Texas is the green line, Hispanic from Puerto Rico is the blue line, African Americans is the black line, and Caucasians is the red line. The numbers in the table correspond to the number of patients at risk. Overall, the chart represents the damage from lupus occurs earlier in Hispanic and Black American population. So increased mortality in Black women. You know, so far we have reviewed the risk factors, we've reviewed the early onset, the earlier rate of damage, and now we're looking at the death rate. This chart looks at the death rate of Black women with lupus compared to Black women without lupus, and also represents white women with lupus compared to white women without lupus. It shows here that Black women with lupus are 3 times more likely to die than Black women in the general public. The comparison with white women with lupus are 2 times more likely to die than white women in the general population. Black women were not only more likely to die from lupus than their white counterpart, but they also died 13 years earlier. None of the white women in this lupus study died within 5 years of diagnosis, while the mortality rate was elevated for Black women from the date of diagnosis on. So again, here, increased mortality in Black women. This chart is also confirming the increased death rate for Black women overall, and is of a more of a recent study here that we're showing, that I think this one is from 2002 to 2004. But what I'm trying to show is that the factor of having lupus does increase the death rate overall, but still Black women are affected more. So here is an article. A recent article did come out from US News this past February, reporting on a study done in San Francisco. They reported that death rates are nearly 6 times higher than expected among Hispanic patients and with lupus, and 4 times higher with expected Asian patients with lupus compared to the white population, white lupus patients. The article goes on to urge the importance of clinicians maintaining a high index of suspicion for lupus patients in the groups in the primary care setting. They need more focus in the primary care setting. The need to refer patients to a rheumatologist quicker and the access to high quality care is important to improve the outcome for lupus patients. So that brings us to the question here. So why is this happening? We reviewed all these the differences between men and women. Then we broke down the different studies looking at charts and onsets comparing different ethnic heritages. So the question is, why is this happening? How do disparities occur? So this question has been looked at for many diseases, not just lupus. But how do disparities occur? Here is a conceptual framework for the understanding of socio-demographic differences and disparities. What has been recognized is the different ways people receive their health care. So here we're going to look at the first level is the healthcare system. There are many considerations at this first level. First, how did the patient come to this facility? Our healthcare insurance really guides us to where we receive our medical attention. Looking at a study of insurance types and SLE outcomes, they looked at the healthcare utilization versus insurance type health maintenance organization, HMO versus fee-for-service, FFS, healthcare plans. The results show that HMO patients needed less clinical appointments than those for fee-for-service. HMO patients were less likely to have outpatient surgeries and the hospital admission than those with fee-for-service plans. So an interpretation is maybe lupus patients with HMO plans either are feeling better and they don't need to go into the clinic for service versus the patient for fee-for-service. This study looked at 900 lupus patients and it compared their outcomes. So the second level to interpret is the operations of healthcare systems and clinical factors. What is the interaction between the patient and the physician? Is the patient able to effectively communicate all the signs and symptoms of what they are experiencing? Does the doctor understand everything the patient is reporting? Are there cultural differences that need to be addressed? Is there an area where healthcare workers need to have an understanding with cultural competency? With the work that I do with this chapter, I work with a lot of lupus patients, and I hear, many different stories and experiences, some good, some not so good situations. And I have to be honest with you, real honest. When lupus patients come to us and they talk about, those experiences that we're having, we really help mentor them. When patients meet a lot of people in the healthcare system, the healthcare workers from just one visit, from the front desk to the person checking them in, checking their vitals, to that initial assessment. We help patients prepare for their appointments. When red flags come up, we help patients navigate the system and reach out to an ombudsman to ensure that any issues can be corrected. Our chapter has trained over 20 patient navigators to talk and listen to patients and help them ensure that they're receiving proper medical attention and proper education. So here we're going to look at the next level, access to care. There is one study that we found that looks at access to care in relation to health insurance and distance traveled to see the physician. It shows that Medicare patients with SLEs travel longer distances to see their physician, suggesting that these patients may face challenges in obtaining the quality and comprehensive care in proximity to their home. Other factors to think of: are they able to drive to their appointments? So do they need to find transportation? Is public transportation easily accessible? Another study to mention is with access to care with socioeconomics. They looked at lupus patients and their zip codes and the level of income made. They looked at the rate of avoidable hospitalizations. The results showed that avoidable hospitalizations occurred more commonly among older and poorer SLE patients. So what does this mean? It shows that lupus patients are having a difficult time finding quality physicians and maybe ending up in the emergency room more frequently, resulting in admissions. This indicates the underutilization or poor access to quality health care. A different study showed that unequal access to health care. They showed that African American patients had fewer primary care providers compared to Caucasian patients. In addition, the physicians caring for African American patients are more likely to report having difficulty accessing subspecialty support to their patients and feel that they're unable to provide high quality of care for their patients. Basically, due to the insurance and access to care, primary care physicians reported having difficulty referring their patients to specialists in order for that patient to receive quality care. That's a big problem. So lupus and access to rheumatologists. This graph shows the access to qualified rheumatologists vary from state to state. And we see it, this is difficult for us. We see this difficulty in access to care in our own state. The reality is many lupus patients have to travel an average of a minimum of 45 minutes just to see their rheumatologist. Some more, some less. And this can be very inconvenient for a patient that doesn't drive. So how did health disparities occur? The fourth level we're going to look at is the social environment context. So it's challenging. It's challenging to disentangle the effects of poverty from race and ethnicity. In some studies, accounting for poverty diminishes or eliminates racial and ethnic disparities in lupus mortality. But in this chart, we show here people with lower income have a higher mortality rate. So this research data is showing that other contributing factors in autoimmune disease can be associated with increased stress levels. We can see a direct factor that people in lower socioeconomic situations struggle to make ends meet, resulting in high levels of stress. In real-world experience, we see this often. A parent will choose their children over their own needs. I know patients that choose to put food on their table for their patients, or for their family, before filling their prescription medication. That's just reality. The struggle is real, and real sacrifice that patients are forced to make every day because they'll always choose their family. And this study here that I'm showing you, this particular study was actually done in Sweden and not necessarily on lupus patients, but it focused in on autoimmune disorders and how it contributes to stress. So different exposures among racial, ethnic minorities, and the poor may also contribute to increased health disparities. So some examples include substance abuse. It is an epidemic in itself. It can also be a contributing factor for negative lupus outcomes. Smoking is associated with worsening lupus outcomes and is more prevalent among low-income communities. Smoking in general, overall, it's just a bad habit, but for lupus patients, it can even worsen the disease. So one of the gold standards of care for lupus patient is a medication, hydroxychloroquine or Plaquenil. It is known that carcinogens in cigarettes decrease the half-life of the medication. So if a patient smokes or is around heavy secondhand smoke, it makes the medication ineffective. So, eliminating smoking is the #1 modifiable risk factor to help lupus patients improve their quality of life. Poverty is also associated with poor diet, which can lead to comorbidities such as obesity and hypertension. So different exposures. There are some studies that also show solvents, pesticides, and heavy metals can be contributing risk factors. Like exposure specifically to mercury has been linked to higher levels of ANA and have been seen as a risk factor for association to systemic lupus. So, okay, the last level we will talk about today is how health disparities occur. We look at the individual and the family context. A survey from our national organization reports that 63% of Americans never heard of lupus or know little or nothing about the disease and its symptoms beyond just the name. This really indicates there is significant opportunity and need for public education. This is one of the reasons why we encourage lupus patients to share their story, especially with their family, because the reality is they don't know what lupus is. Patients themselves can be fierce and take charge to help eliminate health literacy, excuse me. So another contributing factor really seen with the research data that I've shown you all today is that minorities are underrepresented in research. This can be both ethnic minorities and gender minorities. We need better participation in clinical research. The barriers to participation in clinical research are limited awareness and lack of health literacy. Beliefs is there's a huge lack of trust due to our history and the unethical studies in systemic institutionalized racism. So bringing us to beliefs, when we focus in on beliefs, this particular study looks at the difference in spiritual beliefs and focuses on the power of prayer. It also looks at how people are more likely to feel in control of their health, or if there's a belief that a higher being is in control of their health. This study also noted that African Americans are less likely to trust physicians and feel more comfortable to have been treated by an African American physician. Bringing us to mistrust. So looking at mistrust, this particular research study shows that African American patients did not want to start medications that were necessary for their treatment because of the lack of trust in their healthcare provider in compared to other ethnicities. So that's a big problem. So here is the perception of racism. This study shows that some patients perceive discrimination in healthcare. And this can affect the patient from following physician's orders or returning back to the hospital to get medical help. This also is the first study that demonstrated change with the healthcare system by working together to provide anti-racism to help build the trust that lupus patients are looking for. So a statistic within this study showed that 56% of African American patients compared to 32% of white patients had higher perception of discrimination in the healthcare. So the conclusion of this study is the perception of racism in healthcare were more common among African American patients than in white patients with SLE and were associated with depression. Interventions aimed at modifiable risk factors, like working on trust in providers, may reduce higher perception of race-based discrimination in SLE. So here in summary, we have reviewed all of these topics. We've gone through all of these little bullet points here, but biological determinants may explain the difference in prevalence and incidence of lupus in the morbidity and mortality due to lupus among racial and ethnic minorities compared to Caucasians. However, significant racial ethnic disparities in healthcare, they do exist. Access to and participation in research is also limited among the minority groups. Acknowledging the presence of disparities and understanding the factors that are contributing to them is the necessary first step. More research is required to understand the differences and to find solution. But really studying these variables that are discovered is the actual cure. You know, an actual cure is possible. If we could really get all of these research initiatives going, we could truly find a cure one day. We need to acknowledge that the reason why we're here today is to specifically talk about health disparities. We need to learn more. We need to learn more of the presence of disparities and understand the factors that contribute to them are important initial steps to move forward. More research is required to understand these differences and to find solutions. So how do we move forward? You know, first, I want to thank you guys for participating specifically in this program. Raising awareness is the first step to take control and fight back. It's important for lupus patients to speak up and be heard. We need to empower lupus patients with education, and they can teach their families to create stronger communities. We need to understand why these disparities exist by funding proper research. Then working on the data collected to act and to make real change. This change will reduce the rates of disparities in our community. Lastly, a major impact to move forward is through advocacy. If you don't like what you see in our democracy, you need to vote, not just in presidential elections, but in all elections. You know, put the local government officials in charge here in the state of Ohio as well. Get involved with local initiatives. And you can help the chapter here in Ohio by signing up to be an Ohio advocate. Just simply visit our chapter website and sign up. So you can visit lupusgreaterohio.org to become an advocate. This entire month, this entire month of March, past March, we have dedicated the month to making sure our government officials know lupus. Over 3,000 lupus advocates participated in the annual National Lupus Advocacy Summit. We all ask government officials to understand lupus, and we ask them to continue funding in research with the National Lupus Patient Registry at the Center for Disease Control and Prevention. We ask them to continue funding for lupus programs at the Department of Defense. We ask them to continue funding for lupus programs in the Office of Minority Health. We ask them to continue funding at the National Institute of Health. These important initiatives can make the changes we're looking for. We need to support policies that cultivate trust in our healthcare and communities, and to create policies that support anti-racism. So here is, you know, I want to encourage everyone that's joining today is to continue the conversation, continue to be fierce. And a way that you can continue the conversation, share these things with your family, your friends, is by visiting BeFierceTakeControl.gov. And I know my presentation was a little bit longer than expected, but I do have just a short 3-minute video that I wanted to share with all of you if I can get it to go. Just 1 second here. Okay, I think I'm unmuted. So that video that I just shared with you is definitely more impactful than making your family sit through the presentation that I just gave. But I encourage you all to continue to have the conversation with your family. And that brings me towards my references here and any questions that we might have. And actually, I'm going to see, you can comment, use your comment box if you guys have any questions. And I guess I'll turn it back over to Adrian.
Okay, so thank you, Leslie. I just want to say, I mean, just listening to your presentation, you know, I know a lot of the facts and statistics and all of these little things, but when you put it all together in the presentation and you present all of these facts, it's so startling and it's so sad in so many ways. And, you know, it just makes me want to advocate more and do more to make change. But thank you. It really was amazing. And it was very informative to see all of that put in front of us in, you know, one spot. And I know it's even bigger than that, and there's so much more, but I appreciate that. So thank you so much. I know I am seeing right now, somebody's asking about recent studies from the national meeting saying that the Asian death rate is highest. Do you know anything about that?
So I did bring that article up in my presentation. It was from the US Today News. And so, yes, that recent study was done in San Francisco. It was actually published in February, and it is showing an increased number in the Hispanic and Asian communities, that higher rates are there. So I'm happy to, any of these articles and all the statistics and research is on the reference page, but anyone can always email me and I'd be happy to forward over the research articles that I found and pass them your way if you'd like to dig in a little bit further.
I know we're also getting a request for the video as well right now, so.
Okay, so the video is, please visit that website that I just showed you. Actually, Adrian, yeah, the BeFierceTakeControl.org. That's where you can find a lot of additional resources and watch that video and share it with your friends and family to please continue the conversation.
Okay. I know there's a couple other questions that some people had submitted a little bit before, so I was just going to touch on a few of them. One of them is, as an RN and a person that works with lupus patients, what is the biggest challenge you think facing minorities with lupus?
That's one. You know, I think it goes back to being individualized. Like, it depends on each patient, you know, what is being affected. But the biggest thing is that we need to talk about it. You know, we need to bring awareness to it and figure out how we can be better at raising awareness and speaking out. So it really goes back to the person. What are the issues that you're facing? You know, is it access to healthcare? Do we have issues there? Is it your support system doesn't understand you? Then we need to address issues there. And so I guess I would encourage that person to reach out to our chapter and know that we have 20 patient navigators across the state of Ohio. No matter where you're at, we're really trying to find people in your community so that you can relate to them and talk to them. And maybe we just need to assess what your particular issues are, and we could work on that together. So maybe it's access to care. Maybe it's the level of understanding and education programs for your family that can jump on. So I really feel like it's more individualized to the person than more so to ethnicity and race and minorities.
Okay. And is lupus more expensive to treat than other diseases? And how does the cost impact care for those with economic challenges?
That's a really good question. So, I mean, I think it's a no-brainer. It is expensive to be chronically ill, right? And our national organization put out a statistic out there that the average annual healthcare cost for a lupus patient is $33,000 a year. And that is more than, you know, that could be higher, the medical expense could be higher than what their actual income is. So how do patients afford that? In comparison to other diseases, I'm not sure. I'm sure there's, you know, higher and lower, but I know for the average cost for a lupus patient is $33,000. So I mean,
per year, correct? Per year? Per year. Yeah.
Mm-hmm.
Yeah. It's an expensive disease to have for sure.
Yeah.
We have another question coming in. It says, I think we need more literacy level information. Do you have different language information to share?
Oh, yes. Yeah, you can check out our website or contact the office. We do have information in Spanish, Chinese. We do have literature that's available in different languages for sure. And actually, the board chair of our organization helps us with interpretation with Hispanic. So anyone speaking Spanish can call the office and we can connect and talk. And we have ways to connect with people that need help.
Yeah, I think the biggest thing is reach, if you can reach out to the office, and it can be through an email. If you don't speak English, that's fine. Just reach out through maybe an email. We can translate and try to get that information to you. So certainly there's information available. I think I'd like to give maybe one more question, and then we can move on. If we have time at the end, we can answer more questions. Do you think health equity is realistic for lupus patients? Will we ever get there?
I hope so. I think that's a big question in itself, because it's almost like I hope to see that in my lifetime. I know personally for me, I just had a daughter. I am teaching her kindness, compassion, acceptance, and things like that. And I think if we can all be kind to one another and realize other people need our help, it is our responsibility to take care of our friend and neighbor, that it is possible. But it starts with the education and understanding why is this happening and being able to help one another. So in respects to, can I see this happening in the future? I want to say I hope so. I know I'm instilling change in my family and recognizing the difference between right and wrong, but I think it takes all of us as a nation to really come together to say, what are the problems here and how can we help one another? So that's a big question. I want to say yes. I hope I see it in my lifetime.
Okay. Well, thank you. I think your presentation was just excellent, and I know it provided a lot of information, and also hopefully created some questions for audience members to begin to say, what can I do differently, and how can I impact other people maybe that have different challenges from my own? So I think that's an important thing, and hopefully we were able to do that. So thank you, Leslie. Really appreciate it. And I'd like to move along here, and I just want to introduce our next speaker. We are very honored to have our next speaker, who is Yvonka M. Hall, MPA. Yvonka is the Executive Director of the Northeast Ohio Black Health Coalition. She has an MPA from Texas Southern University and a BA from Notre Dame College. She is a native Clevelander and graduated from John Marshall High, where she was inducted into their Alumni Hall of Fame. In addition, she is a Cleveland Plain Dealer homegrown hero for her work addressing food insecurity. In 1974, the murder of her mother, Yvonne Boston Hall, dramatically changed her life. Her childhood promise to use her life to help others has led to the creation of cutting-edge programs and impacted thousands of people's lives. She's a published author, lending her story, The Making of a Public Health Emergency, to the book Not Far From Me, Stories of Opioids and Racism, Hypocrisy, and Bar Faith, A Moral Challenge to the America I Love. She's currently working on her first book, The Cure for Black Trauma Injustice, I'm Tired of Being Sick and Tired, which will be released in 2021. She's a mother, a grandmother, an activist. I'm sorry, I just lost my place there. And she is deeply impassioned and involved in social justice activities locally and nationally. Her strength and tenacity will save many children from the lifelong impact of lead poisoning. She is currently working to push for a ban on menthol products, creating a menthol-free Ohio following the lead of Massachusetts and California. She is a member of numerous organizations locally and nationally. She is a nationally recognized congressional award-winning health disparities expert and has served as an expert offering input to televised and print media, and speaks all over the country about effectively engaging the African American community, the art of community engagement. She's an activist, leader, influencer, speaker, researcher, and philanthropist. And that is quite a biography right there. So we are thrilled and to welcome Yvonka M. Hall to our program this evening. Welcome, and the floor is yours, Yvonka.
Thank you. Thank you for having me. I hope you can hear me okay.
We can.
And let's see. Let's get you to my screen. All right. So, I want to thank you all for inviting me here to speak. I think that being able to talk to people about the issues that are impacting them, particularly around lupus and other chronic diseases, when we talk about um, particularly the African American community, the rates and prevalence of lupus in our community, the age of diagnosis, the things around eating and rest and smoking and stress, environmental factors. But we also have to remember that we are in a world called COVID. And a lot of the symptoms of lupus actually mirror the symptoms of COVID. And so, since we have a lot of people who have not been going to the doctor, particularly African American women, to take their regular exams and physicals yearly, um, our prevalence it may be a lot higher than what we're seeing because everything is determined by those doctor visits. And so it's important if you have not gone to the doctor, that you go to the doctor and make sure that you are checked. That is so important for our community. So for me, working to educate, advocate for the community and empower the community is more than just dropping in. So basically, what I want to highlight, the Northeast Ohio Black Health Coalition, our work as a leader in the quest to address health disparities in the African American community. Um, Understanding key terms: fierce, showing a heartfelt and powerful intensity. Be fierce. And disparities, health disparities, preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. Our mission, the mission of the Northeast Ohio Black Health Coalition, we are a social justice organization that was created to address the impact of racism on African American disparities, including policy inequities, historical trauma, food insecurity, research, behavioral health and addiction, health promotion by working to empower, educate, and advocate for health equity in underserved communities. Race and racism. Why is it so important for us to talk about race and racism today? It is important because race originally was our language that we spoke. And then in the 1700s, because of slavery, it began to be a practice of using physical traits, and so we use those physical traits, and those things became part of what we look at as racism. And racism is a belief that a race is a fundamental determinant of human capabilities, and that racial differences produce an inherent superiority of a particular race. Those things are important in the context of what we're talking about around chronic disease, particularly around healthcare access, where people live, where they work, where they play, where they pray. All of those things are very much things that we talk about every single day when we're talking about chronic disease. Race, going from looking at white Americans and saying, rich people are the upper echelons, and then we have poor whites, and then blacks. No matter what your income, you're below everyone else. And so, understanding how those things play out in people's ability to access vital care services and non-biased care. And so, the state of Ohio has an endorsed definition of cultural competences, and it looks at is the continuous learning process that builds knowledge, awareness, skills, and the capacity to identify, understand, and respect the unique beliefs, values, customs, languages, abilities, and traditions of all Ohioans in order to develop policies to promote effective programs and services. Keyword: policies. Why are policies important? Because having the right policies can change people's lives. Having the correct policies can create equity. Why cultural knowledge is important? Cultural competence. So we talk about cultural competence, and I just talked about it. And so one of the things that I talk about when I'm looking at cultural competences, I look at two things: that we talk about agencies and how people work. So these things are looking at systems and saying, are systems doing what they need to do in order to get you from A to B? right? And so for me, it's important that our systems have a few more things involved in order for them to effectively get our communities from A to Z. One of them is cultural sensitivity, which sometimes we refer to as cultural sensitivity or cultural awareness, which is the knowledge, awareness, and acceptance of other cultures and others' cultural identities. We have a problem accepting other cultural identities here in the United States. And so that is something that we have to really, really address. And remember that cultural identities you can have these intercultural identities too, depending on where people live, because people who live in different places, although we may have communities that are African American that live on the east side, on the southeast side, but people who live on the north side of Cleveland have other things they may eat, other experiences, other places where they came from. And so those things are things that we have to understand. That leads us to proficiency. So, proficiency, cultural proficiency, is the knowledge, skills, and the attitudes and beliefs that enable people to work well with, respond effectively to, and to be supportive of people in cross cultural settings. Cultural proficiency is the thing that will get us to equity. We have to be able to be proficient in understanding the nuances of people and what drives them. That is so important. We talked about cultural awareness. This is just a longer definition, having a firm grasp of what culture is and what's not, having an insight into intercultural variation, understand how people acquire their culture and culture's important role in personal identities, life ways, mental and physical health of individuals and communities, being conscious of one's own culturally shaped values, beliefs, perceptions, and biases, observing one's reactions to people whose culture is different from their own, and reflecting upon their response. Think about how you look at people, how you respond to people, or if people say that they're sick, particularly if you're in the role of a caretaker or a physician. If your observations are always with a biased eye, then you really need to start checking yourself and looking at what what am I doing to make sure that people have optimal health when they come and seek out my service, and seeking and participating in meaningful interactions with people of differing cultures and backgrounds. If everybody that you hang out with looks like you, talks like you, walks like you need to get a bigger group of friends. Go and talk to some other folks and find out how they live, the things they do. Find out about their culture. And anyway, what is culture? Culture for us is often unconscious. It is the characteristics and knowledge of a group of people defined by a multitude of elements. These include, but are not limited to, the way people dress, their religion, spirituality. I know that in your presentation, you talked about religion and spirituality, and that's a whole big deal because there have been studies that have shown that our young people, our Generation Zs, believe in God, but don't believe in secular religion. So they believe in a higher being, but not secular religion. So those aren't going to be your people that go to church. So if you're doing a church program and you're like, I'm going to go get young people, then that may not be the program that works for you. Understanding about people's rituals. What are some of the things they do? The foods, the things they do around celebrations, because all communities, one of our commonalities is around food and how we use food within celebrations. And so those things are, those having multicultural potlucks is what I used to have when I worked in the office place. And we would have those all the time. So we would have an opportunity to eat things that other people brought to the table. Rites of passage, values, family roles, social economic status, um, public and social behaviors, your language, decision-making processes, sexuality, your health habits, age. I would hope that I talk and do things differently than my grandmother, who is 90 years old. She has a different worldview and a different bird's eye view of the things that have happened because she knows past history that I can only read about in books. And then disability status, understanding, what happens when we are working with people who have different types of health issues or mental health issues, and then understanding others that we may not have on this list. So just think about all those things that how we look at culture. Now the historical basis. And so for me, this historical basis is so important because one of the things that we don't do when we look at the African American community, or one of the things that we do is we judge and say, well, you've been here longer than us. I just don't understand how come they just don't have a better grasp of things. So being here longer than others and having a grasp of how things work are two totally different concepts. So remember that the African American community, 246 years as enslaved communities, 99 years under Jim Crow. Those two periods in time account for 87% of the African American experience. 87%. 87. 13% of African American experiences after the Civil Rights Act. And so when you look at that, that's 13% of our experiences after the Civil Rights Act. And we still talk about, what is the treatment of African Americans? The other thing is around historical experimentation. When we talk about historical experimentation and we talk about vaccine hesitancy or why aren't African Americans involved in studies, we have to understand the historical context of it. We have to understand about the enslaved women being used as gynecological surgical experiments by Dr. Marion Sims in 1845, but also before then. What happened before then? We have to also understand around the radiation experiments of African American children, the Tuskegee experiment with African American men, Helolax, which is Henrietta Lacks, the experimentation that was used. Her cells were used and have been able to mutate since 1951 and have been used to treat all types of illnesses all over the world without little knowledge of her family members and no payment for the billions of dollars that her cell has generated to modern science. Or the University of Cincinnati had a radiation study on adult Black children, cancer patients that lasted for some 11 years. Or when we're talking about the low social economic status, predominantly Black communities that have been impacted by the lead paint study that was done in Baltimore in 1993, or the fact that lead paint and the impact of lead paint in our communities. When we talk about lupus, we have to understand the environmental factors. And so when we're talking about lupus in the African American community, we have to also understand that lead paint impacts every facet of people's lives and their bodies, and we have to understand the ties in with lupus. Also, the forced sterilization of Black women in the South. Fannie Lou Hamer coined the phrase Mississippi appendectomy in reference to the sterilization of Black women and girls in the U.S. South. Historical trauma. And so we have to also talk about historical reverence. So there were two times that the health status of African Americans improved. The first time was between 1865 and 1872. This was the post-Civil War Reconstruction. This was linked directly to the Freedmen's Bureau. Why did the health status improve? Because it established Black medical schools, hospitals, and clinics throughout the South. The Freedmen's Bureau and the legislation, saved the African American community from extinction. Um, and the second time that the health status improved of the African American community was between 1965 and 1975. This was the Civil Rights Movement. So the Civil Rights Act in 1965 outlawed racial discrimination in government funding health programs, provided Medicaid and Medicare. It also allowed hospital desegregation, integrated staff and patients, and it provided us with community and neighborhood health centers. You being able to go into a health center and have doctors and nurses and lab techs who lived in your community, who looked like you, who talked like you, who understood the foods that you ate and the things that you do made a difference in the health status of African American communities. And that would be the same when we're looking at the Asian Pacific Islander community and the health centers that were created within their communities also. And in 1975, the post-civil rights movement gains were halted. We started losing everything. Since 1980, we've had a big decline in the health status of African Americans. You know, we can tie it to busing the war on drugs, black flight, and white flight out of communities, the closure of mental health facilities, the opening of prisons. Um, but we know that since 2016, um, with the Affordable Care Act, and with the Black Lives Matter movement, what we have seen is Black life expectancy has dropped. Black life expectancy dropped from 75 to 72 years. African Americans have lost 2.7 years of life since 2016. This is our lowest life expectancy since 2001. But we also have to look at COVID, you know, because right now when we're looking at these things, we're looking at heart disease, um, cancer, and COVID as a leading cause of death in the United States over this past year. And COVID has had a detrimental impact on the Black community. African Americans are about 2 times more likely um, to be hospitalized than whites with COVID, and about 1.9 times more likely to die. And so we have to make sure that we're looking at anti-racism in hospital settings, and the impact of racism on healthcare and on the care of people who are going in for services. This is day 55 for me from COVID. I am a long hauler. I got COVID because I was trying to save my grandmother. Someone dropped in her house from out of town. 2 days later, I went to see my grandmother. My grandmother was sick. I tried to nurse her back to health. And she had to be hospitalized, but she did good, and she actually celebrated a birthday while in the hospital with COVID, and now she is 90 and at home. Um, and her granddaughter, who is much younger, me, still has a lot of the side effects from COVID. We also have to look at menthol restrictions and the fact that African Americans, pretty much when we're talking about the things around lupus, about 9 of 10 10 smokers in the African American community smoke mentholated cigarettes. And so one of the things that menthol does is menthol, it gives your body a cooling effect. So as you're taking the poison into your system, your body doesn't reject the poison and make you cough. And so menthol stops your body from doing those things. And so that's why it's so important for people who have chronic disease and have lupus, for them not to smoke, because the chemicals in the cigarette smoke are very toxic to them, and they actually make lupus worse. What's at issue here is that Africans are plagued with persistent race-based disparities that have existed for centuries, and this has impacted their health compared to their white counterparts in the population as a whole. Why? In 2002, there was a report that came out from the National Medical Association. The report was called Racism in Medicine and Health Parity for African Americans. I use that word parity a lot. We used it before we started talking about equity. I still use it. And the report was the slave health deficit. But the slave health deficit talked about a couple things. It talked about racism in medicine, and it talks about how it has operated at institutional, intellectual, policy, and in personal levels, and is deeply ingrained in the fabric of the United States culture. And that to eliminate persistent race-based health disparities, the U.S. must implement dramatic changes in policies. Remember that word, policies, again, that hide the structure, functioning, and financing of the healthcare system, and must direct efforts to produce a system and a workforce that is culturally confident and, you know, what I said, culturally proficient in dealing with African Americans or other communities of color. Explicit or implicit bias. All people hold some level of bias. So don't be the person that says, oh, I don't have a racist bone in my body. I don't have a biased bone in my body. We all hold some levels of bias. It is important to note that bias can be detected by others as it may be manifest in physical responses like, oh my gosh, are you about to do that? Body language, your tone of voice, your eye contact, etc. To members of particular groups. Explicit bias refers to the attitudes and beliefs we have about a person or group on a conscious level. Much of the time, these biases and the expressions arise as a direct result of a perceived threat, moving out of the way. When you see people, particularly African American men, grabbing your purse, um, or looking at certain foods that people eat and going, I would never eat that. Implicit bias occurs when someone consciously rejects stereotypes and supports anti-discrimination efforts, but it also holds negative associations unconsciously. So make sure that we're understanding that we all have biases. And so that is one of the parts about how do we get to equity, is that we have to recognize those biases and use those things in order to help move us forward. What must be done? To eliminate persistent disparities, the U.S. must implement dramatic changes in all policies. All policies should include a reparations lens. All policies, all policy is health policy. So whatever policies happen, they directly tie back to health. So everything ties back to health, whether it's education, employment, housing, and health. If there are some deficits anywhere in any of those systems, those policy changes, those deficits impact people's health in the end. We have to be ready to direct efforts to produce a system and a workforce that is culturally proficient in dealing with patients with chronic diseases. Nothing is worse than sitting in front of a doctor and telling the doctor that you have a health problem and nobody's listening, or they're typing on the computer and you're trying to get their attention. We have to understand and examine systems. And we have to understand that when people come into our office with a lupus flare or they're having other types of health issues, that all of these systems come into play at that, whether it's your healthcare system, whether it's the food and food access, education, their environments, policies, transportation, their housing, where do they live? How do they live? Their employment, are they making a living wage? Are they able to afford to live? Economics, do they have a slush fund? Do they have money for emergencies? Because we know that a lot of people are living on the edge right now, and it'll be going on for the years to come. The case for equity. So the person who has your concern about equity, health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. The case for health equity. Affecting change and reform outcomes. We have to be ready to frame issues and provide explanations in culturally relevant ways. We have to understand the complexities and issues based on cultural context, historical racism, powerlessness. We have to be respectful of culturally specific meanings of touch, hugging, handshaking. We have to adjust communication styles to a client's culture. Being too close, being too far away, understanding, what goes on with culture. We have to interpret the client's emotional expressions and considering their cultural backgrounds. You know, I know a whole bunch of people just like me who talk with their hands. I'm not trying to kill anybody. I just talk with my hands. Be willing to expand and adapt your role and practices as needed. That is important for healthcare providers. We have to be willing to adapt. Adapting for us can be the difference between life and death for the patients that are sitting in front of us. Um, Endorse a collaborative approach to planning treatment. Talk with your patient. What works for them? Don't give them a menu that's not culturally proficient. You give someone a menu of things that they don't eat, guess what happens? They're not going to eat it. Obtain and integrate culturally relevant information and themes. Select culturally appropriate screenings and assessment tools where necessary. Determine readiness and motivation for behavioral change if necessary. Integrate cultural factors into treatment planning. You know, if they plan things with their family, you know, hey, get some family members in there so you can plan it together. Encourage patients to be advocates for themselves throughout their treatment. I encourage all patients to be advocates for themselves. I told you 55 days, but I did not tell you that 53 days ago, I was dying and I was on my way out of here, and I had to request of medicine to save my life. It wasn't offered to me. I had to make sure that they knew that I wasn't leaving until I got that medicine. What this means, we have to change the way we engage African American communities. Actually, we have to change the way we engage all minority communities. We have to understand that relationships take time. We also have to understand that trust is not developed overnight. You cannot see me today, you know, and give me some high fives and what's up, girl, and I trust you tomorrow. Doesn't happen like that. You can't change who you are, but you can understand who your audience is. So if it takes a little more time to get to know your patient by understanding your audience, take the time. It will be well worth it. Who do you trust? The belief or something or someone is reliable, good, honest, or effective. Those things are important. You know, who do people trust? You know, saying, okay, well, we're going to have a listening tour or having, you know, some type of way for people to get their expressions out. And then people come in and they're like giving you all the stuff that they were mad about. And you're like, that's not what we wanted to do. Community and professionals, they want a way to voice their concerns. People trust who they trust, you know, so find out who the community leaders are. Who are the people who are respected? They may not be the people that you think are the most respected folks in the community. And so Toni Morrison said it this way. She said, and I love Toni Morrison. She said, racism will disappear when it is no longer profitable and no longer psychologically useful. Wow. So in conclusion, we have to seek ways to get involved with the Northeast Ohio Black Health Coalition and the Lupus Foundation or other community level partnerships. We have to seek ways to advocate for funding for African American organizations or organizations that are serving communities of color. That is important. We cannot do what we do without funding. We have to create ways to improve cultural proficiency and diversity of health related workforce. Now, we have to also understand this. There can never be any more for us without us. We have to insist that African Americans are included in conversations and planning about how to fix Black communities or problems that exist in Black communities. We have to stop allowing leadership to take a missionary approach to fixing us, folks from the outside coming into the communities, insisting that they know what is best for the communities, and subjecting their solutions upon communities without understanding the communities. Um, I am Yvonka Hall, I am the executive director of the Northeast Ohio Black Health Coalition. We are the first coalition in the state of Ohio to focus exclusively on African American disparities. And this is my information. My number is 216-295-0283, and my email is neobhc@gmail.com. And we are found on Facebook, and we also have a website that I forgot to put up. I'm sorry. It is www.neoblackhealthcoalition.org. Let's see. Thank you. Thank you.
Thank you, Yvonka. We really appreciate it. And, you know, throughout your entire presentation, all I kept thinking was something that my boss says to us, that's Suzanne Tierney, says to us as her staff all the time, and that is seek first to understand, then be understood. So she's always encouraging us to listen to others before we speak. And so I found it very, you know, I kept hearing that as you were talking throughout your presentation, and really taking that time to understand other cultures, other communities, and really understand where they're coming from and why they have those perspectives, and hopefully that helps change, you know, if it's a physician, maybe their treatment of their patient, or you know, whoever it is in the community. So you had so much good information in there, and I really appreciate it. I think another thing that really struck me was when you said the health disparities definition, it's preventable. Like that's a key word, it's preventable. It doesn't have to be this way. And so I think that's really, really important. And I promise you, I heard the word policies.
Yeah.
I heard it a lot, and I'm going to think about it and take it with me. So,
Well, that goes along with Leslie's voting.
yes,
The
vote and policies. Okay, keywords, people.
Yeah.
So I think it's really good. So thank you so much for that. And I do want to ask a few questions. I have a few questions that people submitted and some that are coming through from the other side. And I can see Suzanne saying that she is praying for your health. She thinks you look great, and so she, definitely wants you to know that we are thinking of you and wishing you good health. But it sounds like you're getting there and well on your way. So one of the first questions we have, it says, why don't doctors realize a person might be stressed because they are not taken serious by healthcare system when they are sick?
You know what? I don't even think that they don't realize it. I think that a lot of times what happens is they have a 15-minute window. And in that 15-minute window, they are preparing for the next patient. So they have to see you get out as much as they can from you. And that's why it's important for you to go in as your best advocate. Go in with your questions. Write them down before you go there. And then don't let them walk away without answering them. You're like, you got your paper here? You're like, yeah, I got a few things here. and start and don't stop until you finish. Get all of your stuff answered while you're there. And if you have a doctor that's insensitive like mine, because I also have cancer, I have thyroid cancer, and so if you have a doctor that's insensitive, mine isn't insensitive anymore. I think he learned his lesson because he had the wrong patient. But if they're like looking at their computer more than they're looking at you, tell them that the next time you come, or right there, like for me, I kind of like smack the computers like the end, like you won't be looking at the computer, you need to look at me. um because I think that unless you can look at my face, because there may be things in either the stuff that I'm saying, or you may notice that I've had a stroke by either if my face is twisted, that you can't see if you're looking at a computer. There may be other things that are going on. You may be able to look at something that's going on with my eye. You may see the ring and recognize that I'm having a cholesterol issue and need to go get my cholesterol checked. You can't see that if you're looking at a screen. And so it's important for us to make sure that our doctors, in order for us to receive optimal health, that we have to make sure that they're focusing on us.
Right, right. I think that's really important too. And especially as lupus patients, we often don't look sick. So you're going in there, you don't look sick, but you're really not feeling well. So, you have to be your own advocate, and you have to make sure, it's like what you said, I need you to look at me, whatever is important to you in terms of communicating with your physician, making sure that they understand that. So that's a very, very good point. Interestingly enough, a pre-submitted question to us, do we know if the Affordable Care Act closed gaps in disease disparities, or did the numbers remain largely the same? So I saw your presentation sort of answer that, and I was surprised by that.
Well, so this is what happened. So when the Affordable Care Act first came out, the rates of like about 19% of African Americans were receiving their services through the Affordable Care Act. But then when they took all the marketing dollars away and not letting people know, like you knew it because you saw the commercials on TV when the exchanges start, like when you had needed to do this, when you need to do this by this, you got a lot of emails, because remember when it first started, we were getting emails like every other day.
Right.
I don't know about you, but my mailbox was flooded. It was like, share this, do this. And I mean, I even have it devoted to my website. And all of those dollars went away. And what happened is people thought that because the Affordable Care Act was being challenged, that it was gone. Because the community doesn't know the difference between challenge and it ended. They just think that because it was challenged and that, oh, we saw that they were going to take it away, that it was gone. And so that 19% dropped to 11%. And now it's even lower. And so one of the reasons that the Biden administration opened it back up is because it was so low. Like they changed the renewal dates, because there were so few people that were actually applying for the exchange. And that was because people had no idea that the exchange was there. So, but the disparities that were there are still there. So that tells you that the disparities are an internal issue and have nothing to do with the exchange, because if the exchange is available, then people will utilize it. But if your care doesn't change, that means that the care, if your health status doesn't change, that means that the care you're receiving is lacking.
Got it.
Some
Got
people
it.
stay with doctors way too long. They need to, like, yeah, some people are with doctors that they should have changed 20 years ago.
Right. Right. So it's all about education and getting the healthcare providers to where they need to be, for sure. What do you think that some things that healthcare providers can do to positively improve disparities in healthcare?
Well, I talked about a few of them. One was understanding your patients, understanding, who they are, where they're from, understanding the community. One of the things that we used to do with residents, I haven't worked at a hospital system in a long, long time, but one of the things that I used to do with the residents is all the residents that came into our system, I introduced them to every single department in the system. Like, I introduced them to the radiologists, the people in the lab, the people in the cafeteria, the housekeeping crew. They knew everybody. You know why that's important? Because patients talk to everybody. Patients talk to anybody that'll listen. And so for the doctors, we were their eyes and ears. But the thing about it is they knew us. So they were able to go to the housekeeper and say, sorry, hey, what's going on? They knew their names. And then the housekeepers were able to say, you got patient such and such. You should check him out because he told me that something is wrong. And the doctor's going, he never told that to me. And so we would get that. I mean, do you understand how often we got patients that were asking housekeeping staff about medical advice that they didn't ask for the nurses because they felt like they were being rushed?
Right.
So the
Right.
housekeeping staff knew more about the patient than or in the fact that triage has to change in order for us to get optimal health for our patients. The triage experience is some garbage, absolute garbage, because the triage experience, saying, look at this happy face. Is your pain level threshold between 1 and 10? But not asking about, do you have food at home? They'll ask about violence, but if somebody's going through a violent situation, are they going to write that down? Do you have food? Do you have safety? Do you have the things that you need in order for you to live? Do you got bugs? Do you have bugs? Not do you smoke, but do everybody else in your house smoke, even though you said you don't, and you have a chronic illness or you got lupus, and you're saying I don't smoke, but everybody in your house beside you smokes. So guess what you do? You smoke. You smoke because they smoke. Or being able to, if you think that you're pregnant, reaching out and talking to your doctor, talking about a well-balanced diet. Is your neighborhood safe? Are you able to go out and walk? If part of what we're going to prescribe you is around fitness, do you have an area that's safe in your neighborhood where you can go? Like, we don't ask those questions in triage. We have people who come in with asthma and breathing difficulties, and we never ask them if they got bugs. We never ask people if they got lead in their house. We never ask them the questions that can actually help change their health status. And I think that we really, for us, our time to do it is now. I think that the time that we have right now in the United States may not ever come again. We have, like, all of the stars have aligned for us to be able to talk to the House, the Senate, and say these are the things that we need on the ground, and actually have people who care enough and are compassionate enough to say, I'm listening, and not only am I listening, I'm willing to help you get to that place.
Got it. I think that's key, is not only just listening, but taking action and helping somebody get to where they need to be by taking action. That's really important, obviously. And I probably could sit here and ask you a million questions. There's a lot that have come in and a lot in front of me. We may have to forward some to you just in the interest of time, but I want to thank you very much. I know it's been very informative. We've had you talk before, and obviously, we're impressed then and impressed now, and you really help bring a lot of these things to our attention and help us figure out kind of what we can do in terms of our work with lupus patients and how important it is to understand disparities, and also working with healthcare providers to help them improve, what they need to do. So it's such a huge issue, an important issue, and I cannot thank you enough for joining us this evening. And I really hope you're feeling better very, very soon. So thank you, Yvonka Paul. We really appreciate it. And I think we'll just have a few more minutes. I kind of want to go back to Cindy as we introduced her before, but I'm going to welcome back Cindy Fisk and from GSK and Us and Lupus, and she would like to take a few moments to share some helpful tools and resources for those of you who are lupus patients or see lupus patients and know lupus patients. So Cindy, the floor is yours.
Thanks, Adrian. Can you hear me again?
Yes, we can hear you.
That was wonderful. It's a huge focus of ours as well. So thank you, Yvonka. I learned a lot tonight as well. But to get back, I think the one thing that resonated was having a voice, right? Being an advocate for yourself. And I encourage you to check out the information and the resources on usandlupus.com. Again, this program was really designed so that those that are living with lupus can have more meaningful conversations with their healthcare team. And I will share with you that we launched a completely new version of the program back in October in the fall of 2020 that included an updated website, several new online resources, really geared to empower those that are living with lupus to take a more active role in the management of their disease. So be an advocate for yourself. Let your voice be heard. You know your body best. Be open and honest in your communication. Yvonka stole something that I share at every event that I present on, and that is really be prepared when you're going in to speak to your doctor, to your healthcare team. Have that list of questions in front of you. And make sure that your voice is heard. You can register for usandlupus.com. There's tons of information that you can go out on the website and read, including information for the caregiver and information on finances and insurance. But if you want to also receive a symptom tracker kit at no cost, you can register with your email address, and they'll send you some tools and resources so that you can start to track and monitor symptoms and be prepared when you're in front of your doctor, whether you're doing it in person or through telemedicine. And then we also have a Facebook community, so I encourage you to check out the Us and Lupus Facebook page. You can like it, you can follow it. But as we wrap up, last but not least, I commend all of you that are here tonight. Whether you're living with lupus, whether you're a family member or you're caring for somebody with lupus, your strength is truly what keeps us going as a company to help you live your best day every single day. And you have our commitment at GSK that we will continue to invest significantly in our lupus research and development program, as well as support the LFA's efforts in this space. And whether that's advocating on the Hill for increased federal funding for research, or supporting LFA's efforts to bring the patient voice into clinical trials, we will be there every step of the way so that a new era will dawn for lupus treatment. So thank you again for allowing us to be a part of this important event focused specifically on addressing healthcare disparities.
Thank you, Cindy. We really appreciate it. As always, we thank you for being here, and we thank you for the support of GSK and Us and Lupus. I just want to say, we're in closing right now. I want to thank each of you for joining us this evening for this program. It is our hope that you understand lupus, health disparities, and the impact they have on healthcare and public health. The actions you take as community leaders can impact outcomes and health disparities and make an impact in the lives of those who suffer. We must join together to make strides and assist in creating change. Your participation shows your interest, your willingness to learn, and your dedication to making a difference, and we are very, very grateful for that. Thank you. I want to say thank you again to our sponsors, the Ohio Department of Health, the Ohio Commission on Minority Health, and GSK and Us and Lupus. Remember to take a moment to fill out the questionnaire at the end of the program that we will send to you as we conclude this program for a chance to win a $25 gift card, which we will announce on Monday. And if you have any questions or in need of resources, please do not hesitate to reach out to our office. That's 1-888-NO-LUPUS, or you can visit us at lupusgreaterohio.org. And I also want to encourage any of you, if you didn't get any questions answered, if you have specific questions for Yvonka or Leslie or Cindy or myself, you can always reach out to us. Our email addresses are on the website, and we can make sure to get your questions to Yvonka. So please feel free to do that as well. But thank you for participating. We really appreciate it, and good night.
Good night, everyone.
Good
Yvonka,
night.
I have some people that I'm going to forward over to because I can see them popping in that they want to connect with you. So I'll be sure to forward those over. So the people that are addressing that, will be sure to get their contact information to you, okay?
All right, thank you all. You all have a good evening.
All right. Good night,
Good night,
everyone.
everyone.
Thank you.